is about laser ablation for prostate cancer, technical outcome by Dr. Walser Eric from the US.
Thank you all for having me here. I want to thank the committee for this invitation to speak and my first visit to Cairo. So thanks again. Good afternoon. We're going to shake things up a little bit. I'm moving away from the artery, and this is a percutaneous speech or a percutaneous presentation. We're talking about laser ablation of the prostate, which is done for two indications, for BPH and also for cancer, for prostate cancer of lower intermittent risk prostate cancers that are confined to the prostate. I'm going to talk a little bit, of course, about the prostate gland, which over history has been shrouded in mystery. Until around 2000, early 2000s, MRI wasn't around, and we really had very poor imaging of the prostate. And in the past, it's been sort of unseen, abused, and overtreated. So I'm going to talk in this presentation. I thought the best way to show the evolution of laser ablation for prostate cancer would be to show you an actual case. And I'm going to tell you a story about a patient that I saw in 2015 and I followed for more than 10 years and treated with a couple techniques that we use now for focal treatment of prostate cancer. On your right there is a template biopsy that's performed often in the OR by urologists for a patient with an elevated PSA but without an MRI. And this is the patient. We'll call him Trey. That's not his real name. But these are active, informed, older males that have a modest PSA elevation, maybe 4.5, with no consideration of the prostate volume. They've had no MRI. We don't know if they have prostatitis or BPH causing their PSA elevation. We just know, or they undergo biopsy. They're typically subjected to annual blind templated prostate biopsies repeatedly, and this gentleman had them for over 3 to 4 years, and they did pick up a Gleason 6 prostate cancer, and he was on surveillance, and he was introduced to what I call the Euro-economic engine, which is here are your choices, buddy. He was given the option for radiation therapy for 42 weeks with androgen deprivation for 3 months, for a radical prostatectomy, and there are no other options given to him. So I heard from him by email, which I typically do with these patients, and he said he stumbled on me, referred by our internet website, sometimes a vendor and sometimes a friend, but rarely a urologist. So these patients come to me typically from self-referral or from a GP or often from a friend. So the 10-year story of FLA for prostate cancer. I'm going to talk briefly about the evolution of focal laser ablation, particularly for this patient for 10 years. And at the end, I'll tell you about the outcomes of FLA for the two methods that we've been using more recently. This is his initial MRI. It was a 1.5 Tesla. You can see it's not a very good image. This was 2015. He had several template biopsies with no diagnosis. And he ended up finding us and came in and had a more precise 3 Tesla MRI, and you can start to see it now on the left. You can see the low intensity lesion in the right peripheral zone medially that showed up on the diffusion weighted imaging, and it was about the size of the tip of my pinky, so maybe a 5 millimeter lesion. And as a practicing interventional radiologist, you see those and you're immediately struck with the fact that you can biopsy this. You don't need a template biopsy, you don't need a blind biopsy, you can actually aim at it. And some of the earlier work was done with some of the Philips systems, which was an in vivo system, DynaCAD, you may have heard of them, DynaTrim, which was a method to do endorectal biopsies of the prostate. And so these could be targeted, and you could use MR-safe needles, and you could actually see the needle in the lesion and know you're actually there. And you have a Gleason 3+4 prostate cancer, which you can get with a frozen section diagnosis from the pathologist if they happen to be present. So again, as an interventional radiologist, the next step is, can you treat these? And these are small, they're 5 millimeters. So you replace the biopsy needle essentially with one of the earlier methods we were using, which was a Visualase cannula and a laser fiber through the same device and into the same lesion. And this is a thermal imaging sequence on MR that shows the ablation being performed over mainly the entire right peripheral zone to get the lesion and a margin. So this is how we started out. This is a transrectal laser ablation using MRI guidance. And this is the post-procedure imaging that shows the ablation zone in the right peripheral zone, and you can see the endorectal probe in place. So I would point out three things from this image. Is one, obviously it's an MR-guided procedure. As somebody who was a leader in the department, you start to realize as time goes on that MR time is extremely precious time. There's a huge diagnostic load going through an MRI every day, and this puts about a two-hour procedure on the MR, which is really economically not terribly feasible. I would also point out that you can see that this is a transrectal biopsy. We're moving away from that in the U.S. and in some other centers because of the transfecal route. In other words, the infectious complications of using this route. And also you can see pretty obviously that the transrectal probe is right up against the rectum and the prostate. And we had a couple instances of rectourethral fistulae because the patient, when they're in the MRI bore and they're having this procedure, it's very easy for them to move and get a rectal injury from the fiber. So this patient actually did really well. And a year later, he has no visible lesions. You see on the right side of the prostate, there's quite a bit of scarring. The peripheral zone is essentially gone. And we follow these patients yearly, and prostate cancer is quite a bit different than other cancers because you can do a year follow-up. So we watch their PSA, and he shows up a couple years later, and you can see his PSA is starting to tick up and trend up higher. And between about over a 10-year period, you can see his PSA is up to 11.2 now, and he's got a focal lesion. And this is an out-of-field recurrence. So this is a metachronous recurrence, not an in-field or scar-based recurrence, which suggests failure, but more a second primary. And you can see it showing up here on the MR. So as he's gotten older, we've also evolved, and you can see that now treatment of this lesion has moved to transperineal, as we were trying to do. And this is a transperineal ultrasound. And the better imaging equipment now shows this lesion really well in the lateral portion of the left peripheral zone, as well as the scarring on the right. And you can do the same thing. You do a transperineal location of this lesion, which you can see between the arrows. We get a biopsy. We have pathologists there, and they give us an instant read in the room. And he has, as we suspected, a 3+4 prostate cancer on the left. And we can go with a transperineal route again. And this is the Alesta echo laser device. And rather than using MR guidance, we're now using ultrasound. We have a lot more room time. We have no radiation. We have real-time monitoring of the ablation and less risk of infectious or fistula possibilities. And this is the procedure in progress and placement of the fibers in the left peripheral zone for a retreatment. You can see on the left there, that's a hydrodissection to protect the rectum during the laser procedure. And on the right side, the fibers are being activated, and we're ablating the lesion plus a margin using transperineal guidance rather than through MR. And 2 days post-FLA, the left hemigland, we see the ablation zone here. So we did it two different ways. We've really evolved away from MRI, and we've gone more towards transperineal, as the urologic community has done as well. And we've been able to do this procedure more efficiently and safer. So a little bit of the data for laser ablation. This is our first series of about 120 patients with a 1-year follow-up. Again, this is low to intermediate risk prostate cancer. These are not your Gleason 9s. These are Gleason 6 and 7 prostate cancers. And we found a recurrence rate of about 17% at a year with a median 34-month follow-up. So we were happy that that was pretty reasonable and in accord with the surgical and radiation therapy literature. And what more importantly, there was no sexual function, no change in the Shim score, and the urinary function was also unchanged over the time. And the PSA generally dropped about 50%. I've been working with a lot of my colleagues across the ocean in the Netherlands and in Paris and in Italy, and I appreciate all their hard work. And we've pooled our results. And now looking at the transperineal ultrasound-guided procedures, it's very interesting that the recurrence rate at a year is about the same. It's about 17% or a little less than 20%. Which is we feel is a pretty reliable number now. And again, you see the PSA dropped about 50% in all these patients at a year. We did find that there were some predictors of in-field clinically significant recurrences, which was the initial PSA density that was, if it was extremely high, they tended to recur. The ablation volume was a perioperative indication, and the positive MRI findings on follow-up was a very strong predictor of clinically significant in-field recurrence. So the moral of the story, or the take-home points, is that high-quality MR is crucial for evaluation of prostate cancer. Most prostate cancers are not lethal. We have no urgency in therapy, and long follow-up, like 10 years, is pretty common. And that the FLA methods, as you've seen, are evolving, and the safety and efficacy is improving. The prostate cancer management should not be as it has been culturally and traditionally. It should be more like colonoscopy for low to intermediate risk prostate cancers rather than surgery and radiation therapy, and more like colonoscopy, or and we run our section more like a breast imaging department or a men's health department in the management of this disease. Thank you very much.
Questions from the floor? Yes, go ahead, please.
Thank you for your nice presentations. I'm Omar Abdelaziz from Cairo University. My question for Dr. Jafar and Dr. Hisham about how do you get from where do you get your patients for prostatic artery embolization? I know Dr. Shakir get them mainly from the social media, but how can we get them on an academic institution? Like in Cairo University, I tried with Dr. Ahmed Sayed to arrange some meetings with the urologists, and we showed them the results of the technique. They are much resistant about this technique. We tried to get some consensus with them. They can send us patients with large prostate, for example, patients with hematuria, patients with comorbidities even. They are still not convinced. On the private level, they don't even want to co-manage our patients. In private hospital, for example, I need co-managements from the urologists. Sometimes they refuse. I go to the internal medicine doctors for this issue. So I want to know your experience, how to get those patients. And even when the patient go to the urologist, they did not give them idea about this technique. And if they ask about this technique, they say some bad words about it. So they are much resistant here in Egypt about this new technique, relatively new technique.
So I think we can spend a whole session on that, but some big lines. First of all, our patients come from social media, word of mouth, so those we have treated, and some urologists. We are going to family doctors. We talk about this in any opportunity we have. Second thing is that for urologists, I would recommend that you go and talk to them about the low-hanging fruit. Patient on anticoagulations, patient with hematuria that cannot be treated, patient that cannot tolerate general anesthesia. So to be able to start with some of those patients so that they can see the result. But I will actually say something very provocative, is that this is probably one of the techniques we absolutely don't need any backup from urology. That's what I think. So as long as you see your patient in clinic, you follow up and you know how to manage the complications, and Dr. Sharker's presentation was amazing. I think then you don't need urologists to handle this thing. I always recommend collaboration. I'm not saying that you don't need to collaborate, but the collaboration is like love should be bilateral, it can't be one-sided. So until that day, I think you really can take the lead, talk about this, be advocate of the procedure, and don't be afraid of the reaction of urologists.
I totally agree with Jafar, and I would say more. It's moving in a probably more a good way because young urologists, you need to go to more young urologists than old urologists. Old urologists will say always, I've never had any complication with prosthetic surgery. But young urologists don't want to have more complications, especially patient with anticoagulation and patient with a very large prostate. They don't want to go very into more complex surgeries than the old urologists. So I would say most of the patients that are referred by urologists are referred by young urologists, not by old urologists. But the majority are referred also by self-referral, social media, and by doctors, family doctors. You know, I would say family doctors who are GP, but also the doctors in our hospital who has someone of his family who has PPH. They don't want to send him to go surgery, so we send it for more PAE. So you need to start small, and it would grow up. But yeah, I agree. We don't need too much urologist for this. There's no complication need to be deal with urologist.
Actually, I swear I'm not allowed to tell his name, but I did a PAE for a very famous urologist in Egypt, and he is not allowing me, and he keeps on inviting me to their meetings, and he says that it is bad, although he's doing very well. It is a very bad procedure. But my question is, and this is totally scientific, would it be fair to say that all patients should try PAE before doing any kind of surgery, that it is step 2 after medication failure, or when the patient is not? Because it's really very minimally invasive, and it's totally repeatable, and it stood the test of time. I don't think, they always tell me, you don't know the real numbers of recurrence. I tell them you don't know the real number of recurrence. I did so many patients post-URP and recurrence after TURP, so it's both ways. So do you think it is fair scientifically to say that any patient who has no solid contraindication should try PAE before doing anything surgical?
It is a difficult question. I think if you have a large prostate above 50, with a good anatomical consideration, not too much atherosclerosis or stenosis or having like a vascular disease, I think it's fair to be included in the indication, and I tell the patient that maybe it will come back in 5 or 6 or 7 years, or he have to choose. I want to have a radical treatment, or I want to have something that maybe push my treatment a little bit far. Even the recurrence after surgery occurs also.
Very hard.
I agree. But I think you should be not saying, okay, it's a second line. It's one of the lines that could be proposed for patient. I'm not sure it could be a second line. I don't know what.
So I think we have the right to believe, and I believe this, that BE is the best among all options of treating the PPH. This is my belief. But we cannot put this rule because we are not the only player in the game. So the guidelines put by the urologist mainly. So it is very difficult to apply this practically speaking.
I think I agree with what also Hisham said, because the size is important. Some of the smaller size, I would actually say 30 to 40, definitely 40 to 50, you need to be careful. There are other options that can be easier, faster, but at the same, we talked about median lobe, if it's unique in large median lobes. But what is also important to know is that you don't even need to have medical therapy as the first choice. There have been 2 studies showing that as a first choice and second choice, PAE was superior to medical therapy. So these are very strong studies. So I think it becomes a question of patient situation, what do they have, what are the risks, and I agree with you that PAE seems to be the most the least invasive with very good outcome, even if the recurrence is higher than some other procedures.
And I think dealing with the guidelines, as Dr. Shakir said, now it is inducted in the German guidelines because Attila Kovacs did this, and he is dealing very aggressively with the urologist in a very lovable and good way. So maybe when you come and talk to them many times and talk in media and talk to everybody that this is better and they are not doing an honest job, not telling people about it, maybe they will be forced to put it.
I totally agree, because in France they were really skeptical, and now it's in the guidelines. PAE is the guidelines, a small part of the guidelines, but it's in the guidelines. Yeah, you should really push, and I think young urologists don't want to have too much complication. So I think if you want to collaborate with urologists, maybe the best way is to talk to young urologists, because the old generation of urologists will not be very happy to help you.
So before, I just wanted to ask Eric one quick question. Do you see any role for this treatment for BPH at some point?
Actually, yes, I'm sitting here throughout the whole meeting listening to PAE, and I realize it's a wonderful procedure. I don't wear lead anymore, so my colleagues do the PAEs, and they typically, in our department, are doing them for quite large glands. We do laser for 40 to 50 cc glands with very good results, and we actually also attack the median lobe whenever we see it. So I think it is an alternative. There's more literature and more research that needs to be done to establish its role, I think. Yeah, thank you, though.
Do you see any doing a combined procedure, like doing a PAE size and laser?
You know, that's a great question. The question was, can you combine the two? And we've started a study to do just that. It was really large glands to do the embolization first, see how it responds, especially RE, the median lobe, and then do targeted ablation to clean up. So, but that's in progress.
So thank you, everybody. We came to the end of the session, and we should conclude the session because we have a session now. So thank you, everyone.